So I will talk a little bit about the overview of the approach we finally settled on, I think, in using an approach we believe works best in most settings, yeah, but not, and some illustrative findings of that approach, I think, and then a few points on learning. So in terms of overview so we've been asked to do fiscal space modeling in a number of policy contexts with similar policy questions, but yet a different emphasis. One could be termed as a policy question regarding the fiscal space for health in terms of a longer term outlook. Yeah? So the question here would be, given that the health system is dynamic, as Tim pointed out as well, both in terms of population needs and demand for health services, but also on the fiscal side, the economy changes over time. How can we think about fiscal space for health and achieving UHC over, let's say, 10 years or even longer, 20 years? And that is a question policymakers sometimes ask. Related to that was the lower bound and what's the upper bound? What's the sort of envelope we're looking at? Another related question is management graduation and in donors, essentially. And that is a question that came out very explicitly in the HIV sector, where the initial stages of the HIV responses in countries were financed by donors up to a large extent. But that currently we've come to a point where the further scale up of these HIV responses will not probably be funded anymore by donors in many countries. Donors and countries are asked to fund themselves the scale up, and donors may also retreat from countries. So that's the graduation question. And more generally, I think, more linked, I think, to the first question as well, is really how can we fund population entitlements in UHC, but also around quasi-liabilities in HIV. What is really important to say is that the nature of that work and the couching of that policy question had different sort of again, a different emphasis. Sometimes the emphasis was on advocacy. So the question there would be, given how much we need, and often benchmarks such as $86 per capita to reach UHC, etc., would be used. Given how much we have, which would then be informed by the fiscal space modeling, can we advocate for more resources? Because clearly we've got a resource gap. Other exercises are much more to do with planning, bringing ministries of health and finance in a country together to plan health care expenditure within a fiscal constraint. Yeah? And that has important implications for the way you populate these models. And yesterday we had a sort of in-depth small discussion on fiscal space modeling, and that came out very clearly. The scope of work further on was either national, regional, or global. So this is ultimately the way we settled on approaching fiscal space, and it's a four-step process, and I will run you through that process. The first is we start from the resource needs, is how much money does the policy cost, and that is where costing comes in. Yeah, so costing models will inform us about the cost of a health system, and that is how the two are linked within UHC. Then we look at the second stage, there's a second step, which is under assumptions of business as usual. If we take health financing policy and fiscal policy for health as it stands, and we take the sources of funding for the health system as given, and we project these forward over time without taking any new initiative, what sort of resource envelope do we have? And we set that scenario, fiscal scenario, business as usual, out against the resource need over time. And that creates a funding gap in many cases. Yeah? And then we say, all right, the third question then is what are the ways in which we can plug that funding gap? Which fiscal policy initiatives can we take to fill that gap? And the last block is then, okay, what is then a maximized fiscal space set out against the resource needs, and the gap will be smaller or filled. That's essentially how we go about that. Now, when we think about fiscal space, what we found as well is we're working with ministries of health very often for these policy questions, and fiscal space is in the realm of macroeconomy and health. Policymakers are very often not familiar with that concept. So we thought long and hard about how to simplify the notion of fiscal space without dumbing it down. Yeah? And what we settled on is when we say, okay, we think about fiscal space, we focus on the fiscal space diamond, which is a simple concept out of public finance management, which says that resources for health will come from any of the four corners of the diamonds. And that is how we structure that analysis. We look at each of the corners of the diamond to say, donors, can they do more? Public budget, can it do more? Borrowing, can it do more? Technical efficiency, can it do more? So if we start with step one, that is an example of a resource need. So this can, as Tim said, this can be actual cost, this can be normative cost, this can be at country level, this can be at global level. You can plug in anything you want at that stage. But it's important to plug in the right type of cost in function of the policy question and not to mix up normative and actual. That is an important element. And here you see an illustration for HIV in 28 high priority countries in the world, and what that agency, in this case UNH, believes that will cost to fund HIV in these 28 countries. Then we move on to the second step, which is the resource gap under business as usual scenario. And the first thing we need to do here is to build a model that allows us to project forward the economy of a country in order to estimate what the sizes of fiscal space for health into the future. And the way we do it very often is we take a financial programming framework, which is a rather simple yet sophisticated enough model, we believe, and that we populate with, and that is important, with data that are agreed by the countries. And we very often take IMF Article 4 data that are agreed between the IMF and the Ministries of Finance. And the reason why they do that is that when we take our own data, which sometimes we may prefer from a technical perspective, we lose buy-in from people who will have to take decisions based on the findings of these models. Yeah? What we also do, preferably if we can, is we use financial programming frameworks of the Ministry of Finance themselves. So we take those models and start working off those models. That is probably the best option. What we then have to do on the business as usual scenario is what we say is that the share of the public budget going to health or HIV or education or any other area really remains constant over the study period. So we say that the political will in allocating resources out of the budget to a certain area remains constant over the period, or we let that variable evolve with an elasticity we calculate to GDP. So that is no active policy intervention there. What we do for donors very often is we flatline them nominally. Yeah? Either that is for desk-based modeling. If we go to countries and we have an opportunity to talk to donors in country and try to estimate how much they will support the sector in country, we use those data. But as all of us know, that is data that is very, very difficult to get by. So very often in the business as usual, you just flatline them nominally. And what you then get is the first sort of output is different sources of funding is each of these lines. And here you look at at Namibia for the HIV response, the United States government, the Global Fund, etc., will evolve in a certain way over time. And this is a simple, important first output of these models that capture the imagination very often as the policymaker. We are currently in 2010. That is the distribution of the expenditure on HIV in Namibia, and we believe that in 2020 actually most of HIV response will be funded out of the public budget. Yeah? So that gives policymakers a view on, okay, are we on a path to actually be in that situation in 2020, because we know that in that path over that time frame decisions will have to be taken. What you then also get in the step 2 is you set out resource needs to the available resources, and very often you get a resource gap. And here you look at a resource gap over a period of till 2020, and what you very often also see in HIV that is very typical is that the gap decreases towards the end of the study period because the economies grow and actually the resource need for HIV remains fairly constant or goes down over time. So these gaps relative to the economy very often decrease. Yeah? So we've got a gap. So we interact with policymakers, and you say if you've got a policy objective, let's say UHC, or ending HIV by 2030, you've got a funding strategy. Well, if we don't change that funding strategy, we've got a funding gap. So we won't be able, in principle, to achieve that policy objective. So the next question then is, what can we do to remedy that situation? And then we go to the fiscal space diamond. Then we say, okay, let's look at all of these 4 corners, and obviously the most important corner is the public budget. And where in the business as usual scenario we say that the share of public budget to health remains constant over the study period, we will now say, what if we increase that share? So very often that ties into discussions around the Abuja Declaration. It should be 15% of general government expenditure. But again, you can use any sort of scenario of increased share for health that you wish. And again, that will depend on whether it's more of an advocacy piece of work or more of a planning piece of work. Yeah? And what you see here, for example, is the red bar chart is the original resource gap, and the orange bar chart is the reduced resource gap following a higher allocation of the public budget to health or HIV. And so we see that the gap is actually plugged in 2022 instead of 2029. So that is a policy intervention that would reduce the gap that we are facing in achieving our policy objective. What we then also, as Sophia said, very often have been asked to do is to look at innovative financing. Innovative finance is a very broad area that covers an enormous amount of possible interventions, and that merits a separate, I think, coming together to be discussed. So what we very often have done is we looked at some of the mechanisms that were popular in particular countries, and we looked at them in more detail, whether we could increase taxes on certain industries like mobile phone industry, alcohol, tobacco, sin taxes, etc., whether we could increase the tax regimes in place in these industries in these countries, and very often use the additional resources mobilized by the increase in the taxes or imposing a specific levy, earmark that resource to health or HIV. Yeah? One of the learnings here really is that what we, in interacting with policymakers, what we found that originally the focus is very much on the quantity of finance. How much additional revenue mobilization do I get out of a levy on alcohol? But the first observation is there is an important qualitative dimension to these levies as well. Some of them are regressive, and as Sophia said initially, it has no point raising additional revenue for the health sector if you do that in a regressive way. So there is an important discussion to be had about quality of these innovative financing mechanisms. So moving on, we move on to another corner of the diamond, and it's a very important one, which is technical efficiency. So we know that health systems on the whole are not, very often the technical efficiency can be improved, but when you think in terms of fiscal space for health, the question is how do you measure that? Yeah? What figure will you plug into the model as being achievable in terms of fiscal space? I think we've never ever used data that we found at country levels out of studies, although theoretically that should be possible. What we very often then do as a proxy is we convert the findings of a data envelope analysis that looks at relative efficiency of health systems in a pool across 173 countries worldwide, and we are going to try to convert the distance of that particular country we look at, let's say in Namibia, from the frontier, yeah, into a potential efficiency saving in monetary terms. Now, methodologically spoken, this is incredibly heroic. Yeah? What we say is this can only be directionally correct, but not numerically correct. Why it is important, we believe, to have a number in the fiscal space modeling is because if you think it through, ultimately the Ministry of Health will interact with the Ministry of Finance around fiscal space, which is likely going to involve an increased allocation of public spending to health. But as a quid pro quo, the Ministry of Finance will demand that these resources are better used. Yeah? So it is to bring into the policy dynamic, policy negotiation, from a technical perspective, technical fiscal space perspective, you recognize the need of a Ministry of Health to use these resources well. So I think it's almost more in view of the policy negotiation that will follow these type of studies that we are insisting to put a figure in there, which perhaps from a methodological point of view is questionable. You know? Then the last one is provocative, I'd say. So one of the fiscal space corners, diamond corners, is borrowing. And the notion here is, can we explore the notion to borrow for health? Yeah? And that is a notion that is not normally explored by macroeconomists thinking about public budget for the social sectors. But there are reasons, we believe, why that notion is currently being challenged. The first reason is that debt sustainability indicators, as they are typically used, are actually not so much rooted into evidence. The IMF very often says that the net present value of external debt shouldn't be higher than 40% of GDP, but when you scratch that figure a little bit, there is no real sort of hard evidence around that figure. So that means that the extent to which you borrow, yeah, is a policy choice. Yeah? It is not, and many low and middle income countries we work with are not fully aware of that. Yeah? That is one issue why we insist on looking on that as well. Another issue is that they are, especially in HIV and less so in health, but perhaps also in health, reasons to say that you would want to borrow. And these are the fact that many countries that struggle with important HIV epidemics have got a problem of intertemporal spread with resources for HIV. As we've seen, this resource gap very often tail off towards the end of the study period, suggesting that if we borrow today to tackle and control that HIV epidemic and we pay back later, that should be possible. So it's not like a bottomless pit idea. It's an investment, and you pull forward the investment and you pay that off over a longer period of time. The other reason is that many people suggest that it is reasonable to think of spreading the benefit of an HIV program intergenerationally. Yeah? So as the benefit of HIV programs benefit future generations, you could argue that the cost of an HIV program could also be borne by future generations. Anyway, that is a little bit a new area which we also quantify as a vibrant policy debate in there, but it is new, and very often I say is quite provocative because ministries of finance and the IMF not normally go there. What we then end up in the last block is the red chart is the original resource gap, yeah? And then we have reduced resource gaps. The orange one is by a reprioritization of health within a public budget. The slightly less orange one is by adding an innovative financing levy, etc., and earmarking that additional revenue to health or HIV, and the yellow one is done by adding additionally technical efficiency savings. And what we then see is that in this particular case, the gap would be plugged in 2019. Yeah? The message here is you can have, and after 2019 we have a surplus. That means that the different fiscal policy options we have that correspond with each of the four corners of the fiscal space diamond, that a mix of these policy options should give us enough resources to, from a fiscal perspective, achieve the policy objective of UHC of ending AIDS 2030, for example. So that is the way we bring it all together. And then two last slides in terms of what is very interesting as well, I think, is that setting out resource needs is how much does reaching a policy objective cost within a resource constraint, very often leads to having to review, as Sophie also has pointed out, and Tim also has pointed out, to a review of the policy objective. So it is a dynamic game. Yeah? So when you initially say, this is the cost of my policy objective, you then realize you don't have enough money, or the context changes, you will have to review the cost of the policy objective. And one way to do that is to look at the relative cost effectiveness of the interventions and start focusing the benefit package on those interventions that are most cost effective. This is to say that a fiscal space analysis, which is about money, very often leads to health policy reform agendas as well. Yeah? Another and probably most important health policy reform agenda that fiscal space can bring you to is to tie the reforms that the Ministry of Finance would want to see in the Ministry of Health in terms of using money better to increases in the allocation of the public budget for health. So if you embed the fiscal space analysis in a wider health financing reform analysis, and you say, okay, we will reform the payment provider mechanism, we will focus increasingly on cost-effective services within the package, we will try to change the allocative efficiency of the system, you can break down these policy interventions in a number of measurable KPIs, as what we achieved in terms of the way we fund hospitals, put that in a framework, a multi-year framework, where the Ministry of Finance can say, okay, what have we achieved? What did we say we would achieve in year one in terms of health system reform? And if that has been achieved, we will increase funding for health out of the budget. So you create an accountability framework that then sits very comfortably within MTEFs and multi-year budget and planning processes. Yeah? So it all comes together there. All right, so in terms of learning, I think what was really, when we started this work, what was really very difficult is to bring the notion of fiscal space and all its macroeconomic complexity in a way to a Ministry of Health that it captures the imagination of a Ministry of Health planner. That was one of the biggest things I think we were challenged with. And the way we ultimately structured the approach with the gap analysis, the business as usual, and the maximized fiscal space, plus the fiscal space diamond, I think, to a large extent, overcame that hurdle, while still being methodologically robust enough, yeah, is the hypothesis, but I'm sure you will want to debate that. The other finding is that as much as possible use country data. What we've seen, I think, in fiscal space models done and by ourselves previously is there is a tendency to build your own model and to use your own data and to go shop for the best possible data from a research perspective. And the validity of the finance will be higher, but they will be less accepted by country stakeholders. So we find that it's much better to use models that are known in country from the central bank, from the Ministry of Finance, and populate these models by data they accept, and which are rigorous enough. That is very helpful. What is also very important, I think, as a good lessons learned, is in the beginning we sort of went to countries, took notice of the policy question, went back, locked ourselves up in dark rooms for a couple of months, came back with the findings. Yeah? The process is as important as the finance in fiscal space modeling we found. So it is engaging from the start and at regular points throughout the study, the policy makers, which essentially is health and finance, around the process, showing how it is done. You create big buy-in for the findings to come, and that helps a lot with policy decisions that are taken on the basis of these findings. What works best, again, is if fiscal space is embedded in a whole of sector health financing analysis. Works much better than standalone exercise. And I think that goes with costing as well. If a costing exercise doesn't feed into the wider ongoing health financing reforms, and of course as it should be, but it's not always the case, then its effectiveness is much reduced. If you can link costing to fiscal space, but also attach that to further wider health financing reform that is going on, that is very powerful. And a last lesson learned, as I said before, we've been in a pickle by mixing up, I think, planning and advocacy. And although there is not such a clear distinction between both, because I think that the nature of the negotiation between ministries of health and finance as part of the budgeting process has got some elements of character of advocacy for more resources very often. You make your case to finance for getting more resources. Yet you can do that in many ways, and if the idea is to set next year's budget, you are much more in a planning logic. If you are thinking about the longer term, etc., you can perhaps think more of it as an advocacy exercise from the Ministry of Health to Finance. I think that's it. Yeah, that's it.
Okay.